Talk is type 2 diabetes and 3RF, and the speaker is none other than Dr. Manoj Chawla. Actually, he doesn't need any introduction. He is a very well-known national and international speaker, director and consultant diabetologist, Lina Diabetes Care. He has held very important posts in RSSTI, Diabetes India, has multiple publications, technology task force member, very important member of DTech, and very well-known national and international speaker. Over to you, sir.
Thank you, madam, and good afternoon, good evening, everyone. It's a pleasure being here at JPEF. I've had the pleasure of being here last several years, so it's always that favorite time of the year. So thanks to Jyoti and the entire team. My talk is on type 2 diabetes plus more than 3RF. For those who are not figuring it out, I'll keep you guessing what the 3RF is, but I shall disclose that. So identifying and managing the high risk type 2 diabetes, this is supported by Astra, and I'm contracted for this talk. So beyond managing individual comorbidities, does a patient's overall cardiorenal risk affect your treatment strategy? We heard a beautiful conversation today on people living with obesity. So gone are the days that we are looking at people with diabetes just as hyperglycemia. We obviously want to see the larger picture and the presence of comorbidities. So today, when you're evaluating your patient with diabetes, you're seeing whether they have one risk factor. Let's say an individual, a relatively younger woman with just dyslipidemia, or somebody who is a little older but has 3 risk factors. So that's your RF, which is risk factors: diabetes, dyslipidemia, hypertension, and age. Or you have somebody who has 4 risk factors, which is type 2 diabetes, being elderly, dyslipidemia, hypertension, and then also albuminuria. So today, you don't just see the numbers. It's not just the HbA1c or the fasting postprandial. You start looking at the larger picture to decide what should be your strategy. So there is a need to understand the types of risk stratification in diabetes, guidelines-based risk categories, risk stratification by count of different risk factors, management of these risk factors, management of cardiorenal risk by the KDIGO class. Let's look at some guidelines and have a quick discussion on generics, and finally end the session by talking about delaying the disease progression. So there are certain type 2 diabetes patient groups that need your extra attention. Well, you will, if you look at in terms of the KDIGO risk guidelines, you will look at there are individuals who would move from milder to higher risk, and as the number of risk factors and the risk stratification increases, obviously these patients require more focus and attention. The earlier you identify those individuals at high risk, the better the care you're able to offer them and prevent the complications. So let's look at the risk stratification. And there are different methods available, and sometimes this can be a little bit overwhelming for the physician, especially a primary care physician. How to really assess? There are clinical risk factor assessments. That means you're looking and simply counting, okay, there's diabetes, there is obesity, there is hypertension, so on. And then you have the risk score calculators. You're looking at whether you're using the different ASCVD risk scores, the dial score, the record score, so multiple different risk scores, Q risk score, and so on. Then you have guideline-based risk categories. You're looking at what your ADA, ESC, RSSDI, what are the different guidelines being put up? Or you're looking at imaging or non-invasive testing. You're looking at your coronary algorithm code, doing your CT coronary angiography, looking at ABI and those parameters. Or you're looking at biomarkers like HSCRP, which can be so non-specific. So there are multiple such methods. We'll look at some of them to decide what can be done. So let's start with the guideline-based risk categories. And the KDIGO, which I simply find it easy to call it KDIGO, has already recommended risk stratification for CKD based on both eGFR and UACR. In the last couple of years, since this has been well noticed and taken, people have started routinely looking at eGFR and UACR as well, because that is what will give you the exact risk stratification. There would be instances where your individual has a normal GFR, but yet has moderate or severely increased albuminuria, putting them into a higher risk category from the KDIGO guidelines. So which is where today you need to look at both the parameters. Somebody who just has a normal GFR and no USCR or no increased microalbumin is fine. But the moment there is leakage, even if the GFR is normal or even raised more than 90, you're already looking at grade 1 CKD there. So which is where you need to look at both these parameters and then stratify. The other aspect is by looking at the count of risk factors, which we mentioned. Simply somebody who has hypertension. So the most common conditions in diabetes, comorbidity, hypertension is 82%. Obesity is 78%, dyslipidemia 77%, CKD 24%, CVD 22%. There are overlapping risk factors, and this is common in Indian type 2 patients. Those who having hypertension and hyperlipidemia, and this is along with diabetes. So multimorbidity in your people with type 2 diabetes is huge. So along with diabetes, having two more aspects, hypertension and hyperlipidemia, 67%, overweight and hyperlipidemia 62%, hypertension and CVD 20%, hyperlipidemia and CVD 20%. So this is how the comorbidities are in our patients in India. 1 in 2 type 2 diabetes patients will have more than equal to 3 comorbidities. And as we can see, the percentage of type 2 patients, so as the age advances of the individual with type 2 diabetes, the chance of him or her having more comorbidities is higher. So somebody reaches an age of more than 70, there's almost a 68.5% chance of having more than 3 other comorbidities, which could be hypertension, could be albuminuria, could be dyslipidemia along with diabetes. Also, 40% of type 2 patients have 3 or more risk factors which are out of target. So in spite of the best efforts, your number of patients who are not having their risk factors in target is higher. And this is percentage wise what it has shown, that about 32% patients will have more than 2 risk factors not under control, 24% will have 3 risk factors not under control, and so on. Type 2 diabetes plus more than 3 risk factor patients are up to 230% higher risk of MACE. So let's understand what we are saying here. Your MACE, or the chances of any major adverse cardiovascular event increasing, goes high with the number of risk factors. If along with diabetes you have 2 risk factors, the chance of MACE goes up by 60%. But if you have 4 other risk factors, then your chance of MACE is going up by 230%. Similarly, with diabetes and more risk factors, the chances of end-stage kidney disease are going up to almost 930%. That means you're almost sure that if somebody has diabetes, hypertension, dyslipidemia, and maybe obesity or smoking, that the chance of landing up with the renal issues is so much higher. Type 2 diabetes plus 3 risk factors will land up with the cardiovascular death chance of almost 340% when your risk factors are higher. So again, as we're showing here, with each increase in risk factor, whether it's cardiovascular death, it's end-stage kidney disease, all the factors or the possibilities are going higher. And hence, the moment you identify your individual with diabetes with more than 3 risk factors, it's time to think about your strategy again. You cannot afford to go slow. You cannot afford to be complacent. You cannot afford to just be looking at the glycemic numbers. Your focus is going to be on cardio-renal vascular protection and prevention of complications. So is there specific evidence for managing such high-risk patients who have 3 or more risk factors? Well, there comes in dapagliflozin or Forxiga, which is proven to provide maximal benefits in such individuals. The renal specific outcomes in the DECLARE-TIMI trial, what did the DECLARE-TIMI tell us? That you had somebody who, and this is a wonderful sub-analysis from the DECLARE-TIMI where they've divided individuals who participated based on their risk factors. So those who had 1 risk factor besides diabetes, they saw a 40% relative risk reduction from the data from the DECLARE-TIMI. Those who had 2 risk factors, we ended up getting 47% relative risk reduction, and similarly those who had 3 risk factors, the risk reduction was almost up to 80%. That means who's benefiting more by drugs like Forxiga? The ones which have more risk factors. Even with just 1 risk factor, you had a 40% risk reduction. And somebody who's having 3 risk factors, 80%. How can we not afford to give these drugs right from the beginning to patients who have risk factors? What is the percentage of patients with diabetes who have risk factors? Well, we just went through that in the earlier slide. It's huge number where you're seeing the multimorbidity. The hospitalization for heart failure benefit for Farxiga increases in type 2 patients as the number of risk factor increases. So it's not only the renal endpoint reduction, but you're also looking at hospitalization for heart failure. Similarly, with the risk factors increasing, your chances of hospitalization for heart failure have been going up. Is there specific evidence for managing such high-risk type 2 patients? We look at the KIDGO classification again. So up to 59% relative risk reduction in the renal composite with Farxiga in high-risk type 2 patients. And this is, you're looking at again data as compared to placebo, whether it's low risk, moderate risk, high risk, or very high risk. Again, as the risk is going up because of the factors, the outcomes favoring Farxiga are only getting better and better in the renal composite outcomes. Up to 64% relative risk reduction improvement in the cardio-renal composite outcomes with Farxiga in high-risk type 2 population. So this is the previous one, and this has been data by Mosinzan et al., which have shown again similar benefits with the risk factors going up. Importantly, you look at the sub-analysis from declared TIMI again. Farxiga improves the albuminuria compared to placebo. And it's not only improving albuminuria as one aspect. You look at the different subtypes. The improvement from patients who had micro improving to normo albuminuria, you see the data favoring Farxiga. From macro to micro, again you see the data favoring Farxiga. Macro to normo or micro to normo, and similarly macro to normo, all the way from macro to normo. For all these improvements in the renal endpoints, you're seeing benefits for Farxiga. So let's come back to looking at the guideline recommendations for high-risk patients. Well, clearly today for the last couple of years, you're seeing the ADA ESD recommendations telling you that your use of glucose-lowering medications in the management of type 2 diabetes should be considering the presence of comorbidities and risk factors. Your patient has albuminuria or has CKD, any of the stages 1, 2. Your choice of drugs hierarchically moves to SGLT2 inhibitors with proven benefits like dapagliflozin. So the goal is cardiovascular and kidney risk reduction. High cardiovascular disease risk, more than 55 years of age with 2 or more additional risk factors. You're clearly going to be using an SGLT2 with proven cardiovascular disease benefit. In such high-risk patients, is it wise to take any chance? Ask yourselves, do you want to wait for your patients to reach with the cardiologist or the nephrologist, or do you want a patient to stay here? Any cardios, nephros in the hall? No, good. So we want our patients to stay with us and not land up with the other specialties. Also, the high-risk patients are the worst hit by differences in quality with generics. So that's another conversation. We do tend to generalize generics, but there are certain loopholes in how the generics can get approvals in the country by just showing a plus minus 20 to 25% efficacy. And also the ACS patients, acute coronary syndrome patients, generics you cost 3.2 higher stent thrombosis post angioplasty. So these are again some evidences, and which is where you will see when it comes to certain drugs, including platelet inhibitors, you will hardly see a cardiologist not using the innovator drug after such events. They may say use it for 1 year, at least 6 months, and then do what you want, but they are clearly afraid of the loss of efficacy or the impact of generics. The problem is that generics only need to prove bioequivalence. So anywhere between minus 20 to plus 25%, your generic drug can get approval. And where it could mean either compromised efficacy or compromised safety, which in most situations is not preferred, especially as long as your patient can afford or values their lack of progression to complications. Offer all of those patients the benefit of the innovator. There is also a cascading loss of bioavailability, as one generic may use another generic as a reference. This is something very funny. For any drug, the reference drug should be the innovator, but again the loopholes allow them to use when they compare another generic as a comparator for the studies done here. So coming back, type 2 diabetes plus more than 3 risk factors are 340 times higher risk of mortality. Really, do you want to take a chance when evidence and quality are weighing towards Forxiga? A formulation of Forxiga is your dapagliflozin propanediol monohydrate. The other ones may not be the exact same salt. The structure can be different at times, and you can have differences right from molecular weight to the efficacy data that they bring about. Forxiga can also prevent your patients with diabetes and more than 3 risk factors from needing a cardiologist or a nephrologist referral. I mentioned this earlier. The problem is with the multiple risk factors, your patients may require a cardiologist within 5 years of type 2 diabetes, or they may land up with a nephrologist with worsening eGFR and USCR because you were probably looking at just the glucose management and not considering the whole picture as a 360-degree approach. So which is where you do land up giving your patients the benefit of the innovator dapagliflozin, Forxiga, which delays the need for a cardiologist or nephrologist by almost 7 years. These are some wonderful numbers to remember. Treatment of a pooled mixed higher and lower chronic kidney disease risk population with DAPA over a lifetime horizon was estimated to delay the onset of the adverse clinical events. Kidney failure, mean delay 6.3 years. Decline in kidney function, delay by 6.8 years. Hospitalization, delay by 6.2 years. All-cause mortality, mean delay by 3 years. So Forxiga delays the major events significantly, and we're looking at a pooled kidney outcome data. You're looking at more than 40% eGFR decline, hospitalization for heart failure or all-cause mortality. Dapagliflozin plus standard therapy did far better than just offering your standard of care without an SGLT2 inhibitor with proven benefit like dapagliflozin. So the key takeaways from this conversation is the importance of risk stratification. I think that's one thing. If there's a takeaway from this talk, is we should do risk stratification for everybody with type 2 diabetes, which is not just based on how high the HbA1c is. You could use the number of risk factors, you could use the comorbid condition, you could use any of the risk scores, but count of comorbid risk factors is a convenient and effective way. And the message is, don't get overwhelmed by different lectures we're trying to tell you to look at the scoring. Do your simple count, how many comorbid conditions is there. Diabetes, along with that hypertension, dyslipidemia, is there any presence of albuminuria or other risk factors. Focus on that high-risk population which has diabetes plus at least 3 other risk factors, because they are at 340% higher risk of long-term cardiorenal mortality and they need extra attention. Why take a chance when you do have drugs with proven efficacy? Generics can be a chance. And your patients with this kind of risk factor profile do deserve early attention and deserve the best to prevent the worst outcomes that we'll end up seeing, or the need to see a cardiologist or nephrologist earlier in their lifetime. So with that, I thank Asha for giving me this session and the organizers for asking me to speak. I finished well before time, so I'm happy to take any questions on this aspect.
Thank you, sir, for that wonderful talk, as always. It's very important to give SGLT2 inhibitors in patients with diabetes with multiple risk factors. Now we all know that, and SGLT2 inhibitors are part and parcel of all our prescriptions, unless and until if somebody doesn't tolerate it. But this generics, it's actually a real problem. We see 100 different dapagliflozins in the market, and we also hear news that a lot of those have been taken back because of the lack of quality. So when we are giving a drug with such big hope of reducing risk by around 80% in people with multiple risk factors, the quality of the drug also matters. So whenever possible, it's important to give the good quality originators. So if there are any questions regarding this, we can take it from the audience.
Yes, Rakesh. So I'll repeat the question for those who couldn't hear it. The use of dapagliflozin 5 mg. Where would one use dapagliflozin 5 mg? So, great question, Rakesh. Now, the problem is the lack of evidence for dapagliflozin 5 as vis-a-vis your empagliflozin 10 and 25. A lot of data that you see for EMPA is for 10. So it's still valid to use empagliflozin 10 where you choose to. We do not have data for dapagliflozin 5 milligram. Now, where does one land up using it? One, in India, there has been this perception that our patients require lesser dose of medicine, right? And we've seen that for all. It's not completely untrue till we really land up doing studies. Is somebody going to do a cardiovascular outcome trial with 5 milligram of dapagliflozin in India? Well, it's too much money, so nobody will do it. So where do you land up using it? One is it's also based on the side effects. So in some cases where somebody is suspecting that the side effect or genitourinary infection is because of 10, or somebody already tells you that in the past I had used it and I had some genitourinary infection, but the current situation warrants retrial of the drug, you may start with a 5 milligram and do that. Somehow also, funnily enough, in the renal segment where there is maximum evidence for benefit, people again tend to try 5 milligram, so do the nephrologists. Again, this is anecdotal, people are using it. Is there great evidence for 5 milligram? It's not. But these are the clinical situations which warrant the use of 5 mg. In pediatric heart failure, right. So that's good to know, sir. I wouldn't have any idea. So pediatric cardiologists are using it in pediatric heart failure? Oh, thank you for that. I didn't know. So the question was, is there an approval for that? Is there an age approval for? So it's an off-label use in that segment. Yeah, but so that's their data, but probably approval is not. An RCT. And it's very interesting. The other place, Rakesh, I forgot, was in the type 1 population. So there has been some data in the type 1 population. Again, will come with all the... yes,
Depictrail is there with type 1 diabetic population, yes.
So, but it will come with again all the caution of not reducing the insulin too much, of landing up with euglycemic ketoacidosis in the type 1s. Having said that, in the last couple of years, one is revisiting the non-insulin usage in type 1, including SGLTs and the GLPs. So in the years to come, we'll see a lot more of evidence coming up for the SEMAs and others for type 1, where you're using it along with insulin and maybe SGLTs again.